Good afternoon, my students. Today we begin lecture disease of kidney and urinary tract. You know that disease of kidney are characterized by the injury basic morphological components: glomeruli, tubulus, interstitium, and blood vessels. The clinical manifestation of renal diseases can be grouped into reasonably well-defined syndromes. Also, the major renal syndromes. Acute nephritic syndromes is a glomerular syndrome dominated by the acute onset of injury grossly visible. Hematuria, red blood cells in urine, mild to moderate proteinuria, hypertension. It is a classic presentation of acute post-reciprocal glomerulonephritis. Also, the next major renal syndrome, nephrotic syndrome, is characterized by heavy proteinuria, hypoalbuminuria, severe edema, hyperlipidemia, and lipiduria. Subtle or mild glomerular abnormalities is characterized by asymptomatic hematuria, asymptomatic proteinuria, or combination of them. Acute renal failure is dominated by oliguria or anuria with recent onset of azotemia. It can result from glomerular injury, intestinal injury, acute tubular necrosis. Chronic renal failure, characterized by prolonged symptoms and signs of uremia, is a final result of all chronic renal diseases. Also, the major renal syndromes, renal tubular injury, are dominated by polyuria, nocturia, electrolyte disorder. They are the result of either diseases directly affecting tubular structure or injury in specific tubular infection. The latter may be inherited or acquired. Urinary tract infection is characterized by bacteria and puree. The infection may be symptomatic or asymptomatic, and it may affect the kidney or the bladder only. Major renal syndrome developed by nephrolithiasis, renal stone, and is manifested by renal colic, hematuria, recurrent stone formation. Also, let's begin discussion about disease of glomerular disease. Glomerular injury is a major cause of renal disease and may be primary and secondary. Primary glomerular disease are characterized by primary injury of the glomeruli. This can be acute and chronic glomerulonephritis, lipoid nephrosis, etc. In secondary glomerular disease, the kidney is one of many organs and systems damaged by the systemic diseases. For example, systemic lupus erythematosus, diabetes mellitus, amyloidosis, etc. Pathogenesis of glomeruli. At glomerular injury is involved endothelial, mesangial, visceral epithelial, and parietal epithelial cells. There are two basic mechanisms of glomerular injury: immune and non-immune. Immune mechanism. Antibody-mediated glomerular injury, for example, immune complex disease. Immune complex glomerulonephritis is observed in the following disease. Primary glomerulonephritis, for example, acute diffuse proliferative glomerulonephritis, membranous glomerulonephritis, membranoproliferative glomerulonephritis, immunoglobulin A sum nephropathy, and cases of rapidly progressive glomerulonephritis and focal glomerulonephritis. Systemic disease of kidney. Glomerular disease in systemic lupus erythematosus, malaria, syphilis, hepatitis, genoch Scholden-Purpure, and idiopathic mixed cryoglobulinemia. Second, alternative pathway disease. The complement system, in particular C3, contributes to glomerular injury in the majority of forms of glomerulonephritis. Alternative pathway disease occur in most causes of type 2 membranoproliferative glomerulonephritis. Some patients of rapidly progressive glomerulonephritis, acute diffuse proliferative glomerulonephritis, immunoglobulin nephropathy, and systemic lupus erythematosus. Other mechanisms of antibodies-mediated injury. Anti-neutrophils cytoplasmic antibodies, anti-endothelial cells antibodies, autoantibodies against endothelial antigens have been detected in circulation, several inflammatory vasculitis and glomerulonephritis. B. Cell-mediated glomerular injury. C. Secondary pathogenetic mechanisms of glomerulonephritis injury. Secondary pathogenic mechanisms are a number of mediators of immunologic glomerular injury, such as neutrophils, mononuclear phagocytes, complement system, platelets, mesangial cells, and coagulation system. Non-immune mechanism glomerular injury. Through most forms of glomerular nephritis are immunological mediated. A few examples by non-immunological mechanisms are found. Metabolic glomerular injury, diabetic nephropathy, hemodynamic glomerular injury, systemic hypertension, deposition disease, cryoglobulinemia, amyloidosis. Infection disease. Inherited glomerular disease, Alport syndrome. This disease destroys sufficient function nephrons. Also, acute glomerulonephritis. The first group of glomerular disease are characterized anatomically by inflammatory alteration in the glomeruli, clinically by complex of findings classically referred to as the syndrome of acute nephritis. It is infection allergic or unknown etiology disease with double non-suppurative glomerulonephritis, very important, non-suppurative inflammation. The nephritic patient usually presents with hematuria, red cells cast in the urine, azotemia, oliguria, and mild to moderate hypertension. Non-renal features: arterial hypertension, hypertrophy of left heart, dysproteinemia, edema, uremia. The patient also commonly has proteinuria and edema. Classification of glomerulonephritis. The glomerulonephritis may be primary or secondary. According to the etiology, it may be bacterial, viral, unclear. According to the pathogenesis, there are two types of glomerulonephritis: immuno-associated and non-immune-associated. According to the cause, glomerulonephritis may be classified into acute, subacute, and chronic. In morphological classification, topography, character, propagation of pathological process are accounted according to topography, intra- and extracapillary glomerulonephritis. According to character of inflammation, non-suppurative, exudative, and proliferative. According to propagation, diffuse and local. Acute post-streptococcal glomerulonephritis. It usually appear 1 to 4 weeks after streptococcal infection or the pharynx or the skin. It occurs most frequently in children of 6 to 10 years of age, but adults of any age can be affected. Duration of disease may 1.5 to 12 months. Cross appearance: kidney enlarged, cortex broad, pale, without markings. Medulla res congestion. Glomeruli just visible as gray vascular dots. The classic diagnostic picture is one of enlargement, hypercellular, relative bloodness, glomeruli. The most often the histological type is intracapillary proliferative glomerulonephritis. Proliferation of endothelial and mesangial cells, and in many cases epithelial cells. Infiltration by leukocytes, both neutrophils and monocytes. The proliferation and leukocytic infiltration are diffuse, that is, involving all lobules of all glomeruli. There is also swelling of endothelial cells, and the combination of proliferation, swelling, and leukocytic infiltration obliterates the capillary lumen. Special stains can demonstrate small deposits of fibrin within capillary luminary and mesangium. There may be interstitial edema and inflammation, and the tubes often contain red cells, coasts, and may show evidence of degeneration. By immunofluorescence microscopy, there are glandular deposits of immunoglobulin G, immunoglobulin M, and C3 in the mesangium and along the basement membrane. Also present, they are often focal and space. The characteristic electron microscopic findings are the discrete amorphous electron-dense deposits of the epithelial side of the membrane, often having the appearance of humps, presenting representing the antigen-antibody complex and the epithelial cell surface. Some endothelial and intramembranous deposits sometimes seen, and there is often swelling of endothelial and mesangial cells. In this slide, we demonstrate histological signs of proliferative glomerulonephritis. You can see this glomeruli is hypercellular and capillary loops are poorly defined. This is a type of proliferative glomerulonephritis known as post-streptococcal glomerulonephritis. In this slide is the post-streptococcal glomerulonephritis, and you can see the hypercellular of post-streptococcal glomerulonephritis is due to increased number of epithelial, endothelial, and mesangial cells, as well as neutrophils, and is in and around the capillary loops. This disease may follow several weeks after infection with certain strains of group A beta-gamolytic streptococci. Patients typically have an elevated antistreptolysin titer. Next variant of glomerulonephritis is rapidly progressive crescent glomerulonephritis. It is syndrome characterized by the accumulation of cells in bone space in the form of crescents, accompanied by a repeat or progressive decline in renal function, frequently with several oliguria or anuria, usually resulting in irreversible renal failure in weeks or months. Morphological signs of rapidly progressive glomerulonephritis. According to histological picture, there is extracapillary proliferative glomerulonephritis. The kidneys are enlarged and pale, often with petechial hemorrhages on the cortical surfaces. Depending on the underlying causes, the glomeruli may show focal necrosis, diffuse or focal endothelial proliferation. The syndrome is characterized histologically by the accumulation of cells in bone space in the form of crescents. Also, continuing morphology of rapidly progressive glomerulonephritis. The histologic picture, however, is dominated by the formation of distinctive crescents, which are formed by proliferation of parietal cells and by migration of monocytes and macrophages into bone space. Neutrophils and lymphocytes can be present. The crescents eventually obliterate bone space and compress the glomerular tuft. Fibrin strands are prominent between cellular layers in the crescents. Electron microscopy may disclose subepithelial deposits in some cases, but in all cases shows distinct ruptures in the glomerulonephritis. In time, most crescents undergo sclerosis. Rapidly progressive glomerulonephritis have next syndrome and occur in the course of three broad disease groups: post-infection, rapidly progressive glomerulonephritis, complicated acute glomerulonephritis, systemic disease, systemic lupus erythematosus or Goodpasture syndrome, polyarteritis nodosa, etc. and idiopathic variant. Also, next variant, injury of glomeruli, nephrotic syndrome, can be membranous glomerulonephritis. It is major cause of nephrotic syndrome in adults. It is characterized by the presence of electron-dense immunoglobulin-contained deposits along the epithelial sides of the basement membrane, in situ formation and deposition of circulating immune complex involving intrinsic glomerular antigens or endogenous and exogenous or planted antigens, are postulated to account for the subepithelial electron-dense deposits. Early in the disease, the glomeruli may appear normal by light microscopy, but well-developed causes show diffuse thickening of the capillary wall. Etiology of membranous glomerulonephritis. Malignant epithelial tumors, particularly carcinoma of the lung and colon and melanoma. Systemic lupus erythematosus, exposure to inorganic salts, gold, mercury, drugs, penicillamine, captopril, and other infections, chronic hepatitis B, syphilis, schistosomiasis, malaria. Metabolic disorders, diabetic mellitus, thyroiditis. In about 85% of patients, their condition is truly idiopathic. Also, morphology of membranous glomerulonephritis. By light microscopy, the glomeruli appear normal in the early stage of the disease or exhibition uniform. Diffuse thickening of the glomerular capillary wall, hence the term membranous. By electron microscopy, the appearance thickening is caused by irregular dense deposits between the basement membrane and the overlying epithelial cells, the latter having lost their food processes. Basement membrane material is laid down between these deposits, appears as irregular spikes protruding from the glomerular membrane base. Immunofluorescence microscopy demonstrates that the granular deposits contain both immunoglobulins and complements. Other change, protein and fatty droplets in the tubular epithelium and stroma, forming macrophages and giant cells from granulomas, is associated with cholesterol deposits. With progress of the disease, narrowing of the glomerular capillaries causes ischemic atrophy of the tubulus and interstitial fibrosis. Membranoproliferative glomerulonephritis. As the term implies, this group is disorders is characterized histologically by alteration in the basement membrane and proliferation of glomerular cells. because the proliferation is predominant in the mesangium. Frequently used synonyms is mesangiocapillary glomerulonephritis. Like many other glomerulonephritis, histologic membranoproliferative glomerulonephritis either can be associated with other systemic disorders and known etiologic agent, secondary membranoproliferative glomerulonephritis, or maybe primary, some without known cause, idiopathic in the kidney. Patients have hematuria or proteinuria demonstrate a combined nephrotic pictures. Also, morphology of membranoproliferative glomerulonephritis. Primary membranoproliferative glomerulonephritis is divided into two major types on the basis of the distinct ultrastructural immunofluorescence and probably pathogenic finding. By light microscopy, both types are similar. The glomeruli are large and hypercellular. The hypercellular is produced by proliferation of cells in the mesangium, also infiltrating leukocytes, and parietal epithelial crescents are present in many causes. The glomeruli have a lobular appearance accented by the proliferating mesangial cells and increased mesangial matrix. The glomerular basic membrane is clearly thickened, often focally, most evident in the peripheral capillary loops. The glomerular capillary wall often shows a double contour or tram track appearance, especially evident in silver of opaque stains. This is caused by splitting of the basement membrane because of the inclusion within it of process of mesangial cells extend into the peripheral capillary loops, so-called mesangial interposition. Injury of tubular structure and stroma take place. In this electronogram, we demonstrate ultrastructure signs of membranous glomerulonephritis. Also, by electron microscopy in membranous glomerulonephritis, the dark electron dense immunodeposits are seen scattered within the thickened basement membrane. The spikes seen with the silver stain represents the intervening matrix of basement membrane between the deposits. Next disease of glomeruli have name minimal change disease, or other name lipoid nephrosis, or other name nephrotic syndrome. As a rule, in children can be often characterized by normal glomeruli or light microscopy, but uninformed and diffuse effect of the food process of visceral epithelial cells on electronic microscopy. Etiology of this disease is unknown. Sometimes maybe immunofluorescence shows no immune deposits. The most characteristic feature of this condition is the good response to corticosteroid therapy. Sometimes you can see proteinuria as is usually selective and is associated with low glomerular filtration, negative change, and hyperpermeability capillary wall. Morphological signs of lipoid nephrosis. Glomerulobastic membrane isn't changed. Tubulars are dilated. The epithelium is swelling, containing hyaline and fatty droplets. Fatty degeneration, necroabscesses, atrophy, desquamation in tubular epithelium take place. Cross appearance, big white kidneys, kidneys enlargement, flabby, yellow color. Next variant injury of glomeruli is chronic glomerulonephritis. Chronic glomerulonephritis is a final stage of glomerulonephritis when sclerosis has eliminated many glomeruli and their associated tubules. This is often the later result of membranous or membranoproliferative glomerulonephritis. Less commonly, post-infection acute nephritis. At the final stage, it is difficult to determine the etiology of the pathological lesion. Morphological signs of chronic glomerulonephritis. The kidneys are symmetrically contracted and have diffusely granular cortical surface. Pieces of renal tissue adhere to striped capsule. Capsule is adherent and strips with difficult. Weight is 50 grams each. On section, the cortex is thin and irregular, pelvis dilated, and there in the increasing peripelvic fat. Such kidneys are called secondary shrinking kidneys. The glomerular histological depends on the stage of the disease. In early causes, the glomeruli may still show evidence of the primary disease. Kidneys from the patients with end-stage diseases on long-term dilation inhibit a variety of the so-called dialysis change that are unrelated to the primary disease. Histological feature is nephrosclerosis. These include arterial intramural thickenage caused by accumulation of smooth muscle-like cells and loose proteoglycan-rich stroma. Calcification, most ovation of glomerular, tuft and tubular basement membrane. Extensive deposition of calcium oxalate crystals in tubulars and interstitial. Acquired cystic disease, increased numbers of renal adenomas and borderline adenocarcinomas. Patients dying with chronic glomerulonephritis also exhibition pathologic change outside the kidney that are related to the uremic state and are also present in the other forms of chronic renal failure. Often clinically important, this includes uremic pericarditis, uremic gastroenteritis, a secondary hyperparathyroidism with nephrocalcinosis and renal osteodystrophy, left ventricular hypertrophy due to hypertension, pulmonary change of diffuse alveolar damage, often ascribed to uremia, uremic pneumonitis. Uremia, hypertension, cardiac failure, or cerebral hemorrhage may cause death of patient by chronic glomerulonephritis. Next, pathology of kidney, amyloidosis of kidney. In this picture, we demonstrate histological signs of this disease. Here, amyloid deposits are seen in glomeruli as the left and arteries of the right. Amyloidosis may be of amyloid type in patient with plasma cells decreasing multiply myeloma, in which amyloid is associated with excess immunoglobulin light chain production, or it may be the AA type or amyloid associated, in which the cause is often chronic inflammatory disease. Next pathology of kidney is tubulopathy, where present fast injury of tubular. This we will discussion about acute renal failure or acute tubular necrosis. Also, acute renal failure is a syndrome associated with acute suppression of renal function, often accompanied by oliguria and rarely anuria or polyuria. Acute renal failure is caused by organic vascular obstruction, severe glomerular disease, acute tubulointerstitial nephritis, massive infection, disseminated intravascular renal coagulation, urinary obstruction, acute tubular necrosis. Acute tubular necrosis is characterized by destruction of renal tubular epithelial cells as a form, ischemia or nephrotoxic. Ischemia, acute tubular necrosis, is called tubulorectin acute tubular necrosis or shock kidney. Acute due to hypoperfusion of the kidneys, resulting in focal damages to the tubules. In this histological picture, we demonstrate morphological signs by acute tubular necrosis. The tubular vacuolization and dilatation here is a result of enteric glycol poison. This is representative of acute tubular necrosis, which has many causes. Acute tubular necrosis resulting from toxin usually has diffuse tubular involving whereas acute tubular necrosis resulting from ischemia, as in profound hypotension from cardiac failure, has patchy tubular involvement. Ischemic acute tubular necrosis develop after next cause etiology. Ischemia may result from following causes: shock, post-traumatic, surgical, burns, dehydration, obstetrical, and septic variant. Next, crash injuries. Non-traumatic rhabdomyolysis induced by alcohol, coma, muscle disease, or extreme muscular extension, myoglobinuria nephrosis. mismatched blood transfusion, black water fever, hemoglobinuric nephrosis. The pathogenetic mechanism of ischemic acute tubular necrosis is explained on the basis of arteriolar vasoconstriction induced by renin-angiotensin system, a tubular obstruction by cost in the lumina or by interstitial edema, back leak of tubular fluid into the interstitium. Morphological signs of ischemic acute tubular necrosis. The kidney are enlargement and swollen. On cut section, the cortex is often widened and pale, while medulla is dark. Predominant changes are seen in the tubulus, while glomerular are normal. Interstitium shows edema and mild chronic inflammatory cell infiltrate. Tubular change are as follows: dilatation of the proximal and distal convolute tubulus, focal tubular necrosis at different points along the nephron, flattened epithelium lining the tubulus, eosinophilic hyaline cast or pigmented hemoglobin and myoglobin cast in the tubular lumina. Disruption of tubular basement membrane, tubulorexis. Nephrotoxic acute tubular nephrosis occur as a result of direct damage to tubular cells by ingestion or inhalation of number of toxic agent. For example, etiopathogenesis, nephrotoxic acute tubular nephrosis. The toxic agent causing toxic acute tubular necrosis are general poisons such as mercury chloride, carbon tetrachloride, ethylene glycol, mushrooms, and insecticide. Heavy metals, mercury, lead, arsenic, phosphorus, and gold. Drugs such as sulfonamides, certain antibiotic, gentamicin, cephalosporin, anesthetic agents, methoxyphylline, halothane, barbiturate, salicylates. Radiographic contrast material. The pathogenetic mechanism producing in toxic acute tubular necrosis is in principle similar to that for ischemic acute tubular nephrosis. Morphological sign: nephrotic acute tubular nephrosis. The kidneys are enlarged and swollen. On cut section, the cortex is pale, while the medulla is slightly darker than normal. In general, it involves the segment of tubular diffusely. In mercury chloride poison, the feature is follows: epithelial cells of mainly proximal convolute tubulus are necrotic and desquamated into the tubular lumina. The desquamated cells may undergo dystrophic calcification. Tubular basement membrane is generally intact. The regenerating epithelium, which is flat and thin with few mitosis, may be seen lining the tubular basement membrane. Nephrotoxic acute tubular nephrosis, the clinical cause of acute tubular necrosis, may be divided into stages. The initial stage, shock, the maintenance stage, oliguric phase, the resort stage, polyuric phase. The clinical cause of acute tubular necrosis. The initial stage or shock stage, lasting for about 36 hours, is dominated by the initiated medical, surgical, or obstetric events in the ischemic form of acute tubular necrosis. Macroscopically, in this stage, you can see kidneys are diffusely swollen and edematous. It is characterized by ischemic cortex and congestion of pyramids, acute renal failure and oliguria, hyperkalemia, and fluid overload in patient develop. The clinical cause of acute tubular necrosis. The maintenance stage, oliguric phase, 2nd or 9th days, is characterized by sustained decreasing in injury output to between 40 to 400 milliliters per day, with salt and water overload. Recent blood, urine, nitrogens, hyperkalemia, metabolic acidosis, and other manifestations of uremia dominated these phases. This is blockage of renal tubulus by necrotic cells and secondary reduction in glomerular blood flow caused by arterial constriction, reduced glomerular filtration. Each stage may be fatal. The clinical cause of acute tubular necrosis, the recovery stage, polyuric phase, 10th or 21st day, is unheard by steady increase of urine volume that may reach up to 3 liters per day. Regeneration of renal tubular epithelium takes place with removal of dead material by phagocytic cells, as well as in the form of cast of urine. As tubulus open up and glomerular blood flow increased, patient develop polyuria. This is because the regenerated tubular cells are undifferentiated and have not developed the specialization necessary for resorption of electrolytes and water. Replacement of fluid and electrolytes is needed to complete competence for excess loss from urine. Hypokalemia rather than hyperkalemia becomes is clinically a problem. The prognosis of acute tubular necrosis depends on the clinical setting surrounding its development. Next pathology of kidney, pathology of tubular, is Tubulointerstitial Disease. The term tubulointerstitial nephritis is used for inflammatory process that predominantly involves the renal interstitial tissue and is usually accompanied by some degree of tubular damage. The term interstitial nephritis is reserved for those causes where there is no primary involvement of glomeruli, tubules, or blood vessels. A number of bacterial and non-bacterial, acute and chronic conditions may produce tubulointerstitial nephritis. Also, in this picture, we demonstrate histological signs interstitial nephritis. In this case of drug induced in the interstitial nephritis, there are some scattered eosinophilic along with neutrophils and mononuclear cells in the inflamed interstitium. Next pathology of kidney is pyelonephritis. Pyelonephritis is a renal disorder affecting tubules, interstitium, and renal pelvis, and is one of the most common diseases of the kidney. It occurs in two forms. Acute pyelonephritis is acute pyogenic infection. Chronic pyelonephritis is a more complex disorder. For example, bacterial infection plays a dominant role, but other factors, vesicular reflux, obstruction, are involved in this pathogenesis. The term urinary tract infection implies involvement of either the bladder cystitis or the kidneys and the collagen system, pyelonephritis, or both. Urinary tract infections are extremely common disorders. Etiopathogenesis of pyelonephritis. The dominating etiologic agents are the gram-negative bacillus that are normal inhabitants of the interstitial tract. Escherichia coli, proteins, Klebsiella, and Enterobacterial, Staphylococcus faecalis, etc. In most patients with urinary tract infection, the infection organisms are derived from the patient's own fecal flora. This is thus a form of endogenous infection. There are two routes by which bacteria can reach the kidneys: through the bloodstream, hematogenous, from the lower urinary tract, ascending infection. Also, obstruction is an important predisposing factor in the pathogenesis of ascending infection. It is incomplete of the vesicular ureteral office that allows bacteria to ascend the ureter into the pelvis. Morphological signs of acute pyelonephritis. The hallmarks of acute pyelonephritis are partly interstitial suppurative infection and tubular necrosis. Macroscopically, the kidneys show variable numbers of small, yellowish, white cortical abscesses, which are usually spatially under 2 mm in diameter, and are sometimes surrounded by a zone of hyperemia. The cortical abscesses are often most prominent on the subcapsule, surface after the capsule has been stripped away. In the medulla, the abscess tends to be in the form of yellowish white lined streaks that converge on the papilla. The pelvic-causal mucosa is hyperemic or covered with fibrino-purulent exudate. Histologically, the neutrophilic infiltration is limited to the interstitial tissue. Some tubules destroyed, abscesses formed, other tubules filled by pus cells, glomeruli usually unaffected. This macroscopically picture of pyelonephritis with microabscesses. The cut surface on the kidney reveals mainly small yellowish microabscesses in both cortex and medulla. This type of pyelonephritis is most typically for gametogenous disseminators of infection to kidney, rather than the more typically ascending urinary tract infection. Clinical feature of acute pyelonephritis. Classically, acute pyelonephritis has an acute onset with chills, fever, loin pain, lumbar tendencies, dysuria, and frequency of micturition. Urine will show bacteria, pus cells, and pus cells cast in the urinary sediment. Complication of acute pyelonephritis. Papillary necrosis is seen mainly in diabetics and in those with urinary tract obstruction. Papillary necrosis is usually bilateral but may be unilateral. Pyelonephrosis is seen when there is total or almost complete obstruction, particularly when it is high in the urinary tract, pelvis filled with pus. Perinephritic abscess implies extension of suppurative inflammation through the renal capsule into the perinephrotic tissue. As the acute phase of pyelonephritis can occur, the neutrophilic infiltration is replaced by macrophages, plasma cells, and later lymphocytes. The inflammatory foci are eventually replaced by scars. The pyelonephritic scar is almost always associated with inflammation, fibrosis, and deformation of the underlying collis and pelvis. Uncompleted acute pyelonephritis usually follows a benign course, and the symptoms disappear within a few days after the institution of appropriate antibiotic therapy. In the presence of unrelieved urinary obstruction, diabetes mellitus, acute pyelonephritis may be more serious, leading to repeated septicemic episodes. This histological picture of acute pyelonephritis. This is an ascending bacterial infection leading to acute pyelonephritis. Numerous pyelonephritis membranes are seen filling renal tubules across the center and right of this picture. This high magnification of acute pyelonephritis, many neutrophils are seen in the tubulus and interstitium in a case of acute pyelonephritis. The neutrophils can collect it in the distal tubulus and they paste in the urinary outcast. This macroscopically one complication of acute pyelonephritis were formation papillary necrosis. The pale white arise involving some or all of many renal papillae are arise of papillary necrosis. This is an uncommon but severe complication of acute pyelonephritis, particularly in persons with diabetes mellitus. Papillary necrosis may also accompany analgesic nephropathy. Chronic pyelonephritis. Chronic pyelonephritis is a chronic tubulointerstitial renal disorder in which chronic tubulointerstitial inflammation and renal scarring are associated with pathologic involvement of the calyces and pelvis. Etiopathogenesis. Two types of chronic pyelonephritis are described. Reflux nephropathy, reflux of urine from the bladder into one or both the ureter during micturition is the major causes of chronic pyelonephritis. Vesicoureteric reflux is particularly common in children, especially in girls, due to congestion absence or shortening of intravascular vesicular portion of the ureter, so that ureteric and not compressed during the act of micturition. Reflux results in increase in pressure in the renal pelvis, so that the urine is forcing into renal tubulus, which are overtubulus following by damage to the kidney and scar formation. Obstructive pyelonephritis. Obstruction to the outflow of urine at different levels predisposition the kidney to infection. Recurrent episodes of such obstruction and infection result in renal damage and scarring. Morphology of chronic pyelonephritis. The kidneys are usually small, contracted, wideness less than 100 gram, showing unequal reduction. If bilateral, the involvement is asymmetric. The surface of the kidney is regular scarred. The capsule can be stripped, of which difficulty due to adhesion to scar. There is generally dilatation of pelvis and blanch calyces. The microscopic change involved predominantly tubulus and interstitium. The tubulus show atrophy in some areas and hypertrophy in others, or dilatation. Dilated tubulus may be filled with colloid crystals producing thyroidization of tubulus, thyroid-like. Interstitium, there is chronic interstitial inflammatory reaction, chiefly composed of lymphocytes, plasma cells, and macrophages, with pronounced interstitial fibrosis. Pelvic closed system. The renal, pelvis, and calyces are dilated and show marked chronic inflammation and fibrosis. Blood vessels. Blood vessels interrupt in the scarred areas through obliterative endarteritis, glomeruli. There is often periglomerular fibrosis. In advanced cause, there may be hyalinization of glomeruli. In this histological picture, we demonstrate signs of chronic pyelonephritis. The large collection of chronic inflammatory cells here is in patient with a history of multiply recurrence urinary tract infection. This is high magnification by chronic pyelonephritis. Both lymphocytes and plasma cells are seen at high magnification in this cause of chronic pyelonephritis. Case of chronic pyelonephritis. It is not uncommon to see lymphocytes accompanying just about any chronic renal disease, glomerulonephritis, nephrosclerosis, pyelonephritis. However, the plasma cells are most characteristic for chronic pyelonephritis. Chronic renal failure. This histological picture demonstrates such pathology. The cortex is fibrotic, the glomeruli are sclerotic, there are scarred chronic inflammatory cells infiltrated, and the arterial are thickened, tubulars are often dilated, and filled with pink cast and give an appearance of thyroidization. Clinical features of chronic pyelonephritis. Chronic pyelonephritis often has an incision of onset. The patient present with clinical picture of chronic renal failure or with symptoms of hypertension. A chronic obstructive pyelonephritis may be insidious in onset or may present the clinical manifestation of acute recurrence pyelonephritis with back pain, fever, frequent pyorrhea, and bacteriuria. Our next pathology of kidney, xanthal granulomas pyelonephritis. This macroscopically picture this disease. Sometimes long-standing infection may be located and form a mass-like lesion. This is a disease known as xanthogranulomatous pyelonephritis. It is unknown but may mimic a neoplasm. Attention. Xanthogranulomatous pyelonephritis, histological signs, this microscopic appearance of xanthogranulomatous pyelonephritis shows many pale to foamy macrophages from breakdown of renal parenchyma with ongoing inflammation. Urolithiasis. Urolithiasis or formation of urinary calculi at any level of the urinary tract is a common condition. It is estimated that approximately 2% of the population expression renal stone disease, sometimes in the later life with male-female ratio of 2:1. Renal calculi are characterized clinically by colic, pain, renal colic, as they pass down along the ureter and manifested by hematuria. Sites of formation: precipitated form in the collection tubulars and pass into renal pelvis where they enlarged. Deposits are formed in the lymphatic vessels of the renal papilla and are extracted into the renal pelvis. Types of urinary calculi. Calcium stones. Calcium stones are the most common composition, about 75% of all urinary calculi. They may be pure stones of calcium oxalate, 50%, or calcium phosphate 5%, or mixture of calcium oxalate. Mixed strevite stones, about 15% of urinary calculi are made of magnesium, ammonium, calcium phosphate, often called struvate. Stockholm stone, which is a large solitary stone that takes the shape of the renal pelvis, where it is often formed, is an example of struvite stone. Uric acid stones. Uric acid calculi are radiculated and like radio-operant calcium stones. Uric acid stones are smooth, yellowish-brown, hard, and often multiply. Cystine stones. Cystine stones are small, rounded, smooth, and often multiply. They are yellowish and wax. They are seen in hereditary tubular transform defect causing cystinuria. This picture demonstrates large renal calculus stone. There was a large renal calculus stone that obstructed the calculus of the low pole of this kidney, leading to focal hydronephrosis, dilatation of the collection system. The stasis from the obstruction and dilatation led to infection. The infection with inflammation is characterized by pale yellowish, then areas next to the dilated calluses with hyperemic mucosal surface. The upper pole is normal and shows good corticomedullary demarcation. Also, urolithiasis, complication, pyelonephritis, hemorrhagia, hydronephrosis. This macroscopically picture Stockholm calculus. Sometimes a very large calculus near fills the callusal system with extension into calluses that give the appearance of the Stock's horns. Hence, the name Stockholm calculus, seen here, is a horn-like stone extends into the dilating callus. Nephrectomy may be performed because the kidney is non-functional and serves only its source for infection. Hydronephrosis is a term used for dilatation of renal pelvis and calluses due to partially or intermediate obstruction to the outflow of urine. Hydrourethria nearly always accompany hydronephrosis. Hydronephrosis may be annulated or bilated. In this macroscopically picture of hydronephrosis, here is a kidney with much more advanced hydronephrosis, in which there is only a thin rim of remained renal cortex. Such a kidney is non-functional and a source for ongoing infection. This process is unrelated, then the problem originates from the urethra office of the pelvis. Unilateral hydronephrosis. This occurs due to some form of urethral obstruction at the level of periurethric ingestion. The causes are intraluminal calculus in the ureter or renal pelvis, intraluminal congestional obstruction, atresia or ureter, inflammatory stricture, trauma, neoplasm of ureter or bladder. Extramural obstruction of upper part of ureter by infection renal artery or vein, pressure on ureter from outside, such as carcinomas, pelvis, prostate, rectum, colon or cecum, and retroperitoneal fibrosis. Hydronephrosis, this macroscopically picture, the raw points of the culprit in this cause of hydronephrosis are ureter calculus at the ureter pelvis ingestion. This kidney demonstrates marked hydronephrosis with nearly complete loss of cortex. Bilateral hydronephrosis. This is generally the result of some form of ureteral obstruction, but can occur from the various causes listed above if the lesions involved both sides. Congestial atresia of the ureteral mecha, congestial posterior ureteral valve occurred, bladder tumor involved ureteric office, prostatic enlargement, prostatic carcinoma, and prostatitis, bladder neck stenosis, inflammatory or traumatic ureteral stricture, and phimosis. This macroscopically picture hydroureter and hydronephrosis. A long-standing obstruction, probably congestion, at the ureter office, through which the metal propaces led to the marked hydroureter and hydronephrosis, seen here. Morphology of hydronephrosis. The kidneys may have moderate to marked enlargement. Initially, there is extrarenal hydronephrosis, characterized by dilatation of renal pelvis medially in the form of a sac. Eventually, the dilated pelvis calculus system extends deep into the renal cortex, so that the thin rim of renal cortex is treated over the dilated calculus, and the external surface assumes tubulate appearance. This advanced stage is called as intrarenal hydronephrosis. The wall of nephrotic sac is thickened due to fibrosis, scarring, and chronic inflammatory cell infiltrate. Cystic disease of kidney. There are several cystic diseases of kidney, some of which produce renal failure by causing disturbance of renal structure. Importantly, some conditions are hereditary. Adult polycystic disease is inherited in an autosomal dominant strain, generally becoming clinically manifested in adult life. Increasing disease is detected in childhood with family screening and ultrasound and examination. Cysts develops and progressive enlarge over a number of years, but remain asymptomatic until the number and size of the cyst is so great that the patient becomes aware of abnormal masses. At about the same time, the replacement and compression of functioning renal parenchyma by the cyst leads to swollen progressive impairment of renal function, and patients develop chronic renal failure and hypertension. Patients with adult-type polycystic renal disease may also develop cysts in liver, lung, and pancreas. There is an associated with biliary aneurysm of cerebral arteries, which with development of hypertension predisposed to intracranial hemorrhage. This microscopically signs a polycystic kidney disease. Here is a microscopic appearance of reversible polycystic kidney disease. Note that the cysts fill most of the parenchyma, and it is hard to find glomeruli. Many of the cysts are enlarged and rapidly enlarged from the center of the kidney on the right margin, like spoke on a wagon wheel. Cystic disease of the kidney, infantile polycystic disease, is uncommon and is encountered at birth. Children develop renal failure with compression of the lungs due to massive enlargement of the kidney. Simple renal cysts are the most common form of renal cystic disease and must be distinguished from the congestion type discussed above. They are widely held to be acquired abnormalities in this increased with age. They contain clear whitely fluid and have a smooth lining. Simple cysts may be single or multiply and vary in size, generally being to no larger than 5-6 cm. They have no effect on renal function, but may rarely become infected or develop hemorrhage. Acquired cystic disease is seen in kidneys left in situ, while patients are treated by dialysis or transplantation for chronic renal failure. The kidney is converted into a mass of large cysts. Hemorrhage into cysts is common, leading to blood staining content. This macroscopically picture multicystic dysplastic kidney. This kidney in patient weighs 3 kg. This disease is inherited with an autosomal dominant pattern, so the recurrent risk in the family is 50%. In adult, in such patient develop kidney failure. This microscopically multicystic dysplastic kidney signs the appearance in multicystic dysplastic kidney or Porter's type second is characterized by large cysts lining by flatulent cuboid epithelium and an environment parenchyma that is fibrotic with island of bluish cartilage and rare glomeruli. These two present macroscopically signs of multicystic dysplastic kidney. Chronic renal failure. This pathology develops very often after nephrosclerosis. Is morphological basis of chronic renal failure. Uremia is final stage of chronic renal failure. Uremia syndrome encompasses a group of clinical and biochemical signs derived essentially from the retention of waste products and the failure to control fluid and electrolyte balance. Glomerulosclerosis or Wilson disease. This is a pus stain in nodular glomerulosclerosis. Wilson disease in a patient with long-standing diabetes mellitus. Note also the marked thickened arterioles and the low right, which is typically for hyaline arteriolosclerosis that is seen in diabetic kidneys as well. These two diffuse glomerulosclerosis paths staining demonstrate diffuse glomerulosclerosis with long-stained diabetes mellitus, present signs of sclerosis of arterias and glomerulus. Also, chronic renal failure. Uremia is characterized by hypernitrogenemia, metabolic acidosis, accumulated of suffices phosphates and organic acid, hyperkalemia, hypercalcemia, anemia, depression of immunological reaction, infection are common and will in turn affect renal function. Arterial hypertension, hemorrhagic syndrome, petechial hemorrhages, erosions, and ulcer in mucus, fibrinous inflammation, fibrinous pericarditis, core villosum, uremic pneumonitis with pleural exudate, uremic gastritis, enteritis, colitis, edema of lungs. The prognosis of final stage renal failure has been greatly improved by dialysis, renal transplantation. Thank you very much. Finish.